What PICU lectures have you had so far?
DKA.
Good.
And then shock.
Shock, okay. Well, those are real common. What I want to talk today about is two also the more common things we see. One is asthma, and the second is treatment of intracranial hypertension, because about 50% of our patients that we see in the pediatric ICU, you'll take care of our trauma and trauma-related sick patients. So I want to talk about those two things, and then these aren't very long sections, but then we have time just to talk about really any questions you have about anything that we do in the PICU. And one thing about the PICU is just our structure is you really are on an island. Ask Dick. Thanks, John. You really are on an island, and although the attendings are there, you don't have fellows, and you don't really have upper levels, although they're around. But the biggest resource you have are the nursing staff. You may take care of 5 EKs, they've taken care of 50. You may take care of 10 asthmatic or status asthmaticus, they've taken care of 100. So they are your best defense and offense. So utilize them, and they will always steer you in the right direction. They're not going to sabotage you or anything, but they will say, no, this is a time when you call Dr. Scott, or no, you need to call him in. And it's not against you, it's just they know that they can see things that may not be going as well. So with asthma, that we've seen a lot of asthma recently, that there's been an uptick in asthma. And what we see in this area has been a huge uptick in status asthmaticus. And there may be a couple of reasons for that I'll explain in a second. But if you look at the biology, we used to be very simplistic about it. We used to say, oh, you get an allergen, it would go to this IgE, and the mast cell would degranulate and get inflammation and get airway symptoms. And that's really a very naive way of looking at asthma. Asthma is a very, very complex with multiple pathways that get you to asthmatic symptoms and bronchial hyper responsiveness. One is you can have an antigen, you can have a bacterial. Almost any irritant that will stimulate the dendritic cells will cause the naive T lymphocyte to respond to a Th1, Th2, both of which can cause significant inflammation. And we can see, and I'll show you on a slide later, that patients that go to this T1 response are usually the ones that come in and try to die real quick. These are the ones that die 5 or 6 days later because they're just not getting better. So there are different biologies, and not all asthmas are the same. So it's important to know that. And it's also important to know that there are probably gender differences. There's certainly race differences in asthma. So we have to look at all of these things. If you look at it, and I know this is busy, but if you look at those that really go on to do poorly, or the ones that are going to die on you, they have really home bronchodilators without improvement. What they'll do is they'll say, I've taken 10 treatments at home or gone through a whole inhaler and I'm not getting better. And I'll talk about the biology of why this may occur. The other is that they've had previous ICU admissions. Previous ICU admission, they need to go to the ICU unless they've just totally turned around and running around, only because if they got this sick, then they have super hyper-responsive asthma, and those are the ones that are probably going to get in trouble. They exacerbated if they're on corticosteroids, so they were at their pediatrician 3 days ago, they got steroids, and they come in and they're exacerbated. Those are the ones that probably need to go to the ICU and at least be monitored for the first 24 hours. Frequent ER visits, less than 10% improvement in peak flow if you can get them to do that. If they have any seizure or syncope related or desaturation, they need to go to the ICU. So those are simple tools just to say who are the ones that I really need to worry about. And this one is what we see here. And the ones that we've come in and had to intubate or we've had to put on ECMO, this is the history that you get. They gave them 100 treatments at home and they're just not getting better. And this is also one of the more important. Oops, sorry. There we go. if you look at status asthmaticus and the ones that die, and remember about 10% death for status asthmaticus. So you can say 1 in 10 of patients come in as severe asthmatic. That's the mortality rate that you're seeing. And so it's not a benign disease. And so if you look at the ones that die rapidly, the ones that come in and really try to die on you, they really have neutrophilic infiltration. Again, more of that Th1 response. And the ones that die 5 or 6 days later, it's much more of an eosinophilic, much more of an allergic reaction type process. And this may be much more of an infectious type process. And so there may be a difference in how these patients do, but all in all, you treat them the same. This is what I get the question the most, what is a good thing to look at ICU admission? And besides the things we talked about early, if they have any altered sensorium, they come in. If they're on continuous inhaled beta-adrenergic therapy, of course, exhaustion, and that's what you see the most is exhaustion. And I'll explain exhaustion, why that occurs. Increase, air entry, PCO2 rising, and any presence of high risk factor for severe attack like we talked about before. But what we see the most common is unrecognition of this. Because they'll say, hey, they look pretty good, but what happens is they've really outstretched their capacity to breathe anymore. Because what happens is kids do this, and then boom. Adults do this. They slowly deteriorate. Kids don't. They go, and drop, just like with shock. They go, and then drop. And that's with asthma. They do this with exhaustion because they have much better, oxygen dynamics, so they can tolerate exhaustion a lot better, but they fall off the cliff quicker too. Arterial blood gases, we get this a lot. We get this a lot from the ER. Do not get them. There's nothing worse than having a baby with an asthma attack and you're trying to get an arterial stick. What does that do to them? They're going to cry. They're going to cry enough trying to get a venous stick, but you can get a venous gas, just as accurate, just as important, just as instructive. You do not need an arterial blood gas. And if an attending says we need an arterial blood gas, ask somebody else. You'll never see the PICU attending ask for an arterial blood gas unless they already have an A line for some reason. So what's the first line therapy? Well, you all know this. I'm not telling anything new, but typically it's albuterol. And handheld nebulizer can be administered either continuously at 10 to 15 or every Q to 5 to 15 minutes, depending on the severity of the bronchospasm. Here's the issue that we see here, is we know that there are about 200 different polymorphisms of the beta-2 receptor. And these polymorphisms, what we're finding is they have various degrees of susceptibility to the beta-2 agonist. So you have some people that are hyper responsive to the beta-2 agonist. Those are the people that come in, they wheeze a little bit, you give them a treatment, they're shaking, they're doing well. Those are the ones that have the hyper responsiveness. What we found is, and this has been described several times, is in African Americans, particularly African American males, they seem to have one of the polymorphisms that is very resistant to beta agonists. These are the ones that get 25 treatments at home and they're still wheezing. And what we found is that they have very, very poor hyperresponsiveness. So if you have someone that is getting high dose bronchodilator and they're just not improving, you need to think elsewhere. Don't keep giving it and giving it and giving it. If you look at all the patients that we've had on either AVCO or ECMO for asthma, they've been all African American males. If you see all of this acute exacerbations have been hospitalized, we looked at this a year ago or so, almost all of them are African American males. And it is because we seem to have a high density in this area of that polymorphism. Does that make sense? So we got to think elsewhere, and I'll give you the alternative in a second. Anticholinergics, which is atropine based. We have tronium, and it's used. It can be used as an alternate to bronchodilator, or I give it also with the bronchodilator. It's has less activity during an acute exacerbation. It's much more of a chronic therapy, although we do add it. It seems to just not work that well, and I don't really understand the biology of that, other than maybe they're just so far beyond that it's just beyond the capability of that drug to help very much. Steroids, the hallmark of all asthma, right? And there's a couple of reasons. One is, particularly with methylprednisolone, it does have free radical scavenging effects, which is why in someone that's severely ill, we go right to methylprednisolone, but not that ill, prednisone is just fine. But not only the steroid effect, but probably a very early free radical scavenging effect. We know that patients with severe asthma have very high airway free radicals. So this is why, if you go to the ICU, this is what you get. You don't really go to prednisone. If they're coming as an outpatient, yeah, they're a little more severe, but they're doing okay. Prednisone is fine. Let them deal with their own free radicals. We have the mechanisms to do that. But methylprednisolone, it's a milligram per kilo every 6. And here's where we've had to go back to old drugs. Because of that polymorphism, the beta-adrenergics don't work. And how do beta-adrenergics work, right? They inhibit the breakdown of cyclic AMP, right? So you increase cyclic AMP, and you increase your smooth muscle relaxation. Methylazathines do this by an alternate pathway. They don't require the beta-2. So what we're doing now with asthma is, particularly the severe asthmatics that we're seeing, is putting on aminophylline. Old drug, we stopped using it 15 years ago because it really didn't work that well. Well, it does in this subset of patients. It works very, very well. So if you see us do this, the first thing you'll get is a call from the pharmacist saying, "You want what?" But there's very good biology behind it, and it's the only alternative that we have. In fact, if you look at the national guidelines now for asthma, theophylline is now in the mix for that reason. If they are refractory to beta-adrenergics, or they've been refractory, then going to theophylline and aminophylline. Aminophylline is the IV form of theophylline. Then that's the way to go in it because it has that alternate pathway. Does that make sense? See, this is easy stuff. And it has some anti-inflammatory effects in the loading dose, 5 to 6 milligrams per kilo, and then it's a continuous infusion. I start at 0.5, but push up to 0.9 pretty quick. So that's aminophylline, and we'll tell you about that time, but bring it up to us if we forget about ours late at night and say, look, he's gotten 65 beta-adrenergics in the ER and he's still wheezing. Then, okay, wait for the steroids to kick in. We're going to give him magnesium. I'll talk about it in a second. But then say, what about aminophylline? Particularly if it's African-American male. Go to that pretty quick in this community. Magnesium, a lot of controversy on that in the adult world, but all of it's kind of smoothed down that the Pediatrics has continually shown that magnesium can cause smooth muscle relaxation. It has very good bronchodilator activity, and it does it by basically competitive inhibition of calcium at the smooth muscle binding sites. And it's 30 to 75, and a lot of people just give 50. I like to give 75 every 6. It can also be inhaled. We have an inhaled protocol. We use it a lot for bronchiolitis. Kids come in, they're not necessarily asthmatic, but you can't call them asthma yet, so it's bronchiolitis, or they have a URI, RSV, and they get a bronchiolitis. Inhaled magnesium, very, very well, it works very, very well. Relieves a lot of their symptoms. You're not curing anything, you're just relieving their symptoms. And so they do have an inhaled protocol in respiratory therapy. Just call them and say, I want the inhaled magnesium protocol, and it's all written out for you. Anesthetics, we do go to that. Ketamine, of course, you can use, and particularly if they go into respiratory failure, oftentimes the sedative of choice is ketamine for this reason. It does have smooth muscle relaxation effects, and it improves airway resistance for some pathways that I'm not sure I understand. And it can work as quick as 15 minutes, so give it liberally. Inhaled anesthetics we occasionally use. We don't do it much more, but if they're continuing to spiral, we usually just go right to medical failure, we just go, what next? And so what we look at, you've given all of this, you've given this therapy, and you start seeing exhaustion. And you know exhaustion. Kids just exhausted. Why do they get tired? Well, if you look at it, if you really cause bronchus constriction in this area of the airways, and of course this simplistic look at the lung, then you get hyperdynamic inflation. And that hyperdynamic inflation, every time you take a breath, you get more in than you're exhaling. So the hyperdynamic inflation gets worse and worse. So what happens is you start getting what's called Autopeep, which is peak peak expiratory pressure. And what it is, it's the positive expiratory pressure that occurs in the alveoli itself. And so it's normally in our alveoli, we're -1, +1 to -1, but you start getting this discrepancy in the airways. So what does a person have to do to take a deep breath? Well, remember the upper airway is 0. So to move any air, it's got to be greater than -8. Taking a normal breath, you generate a negative pleural pressure of -1, maybe -2. If you take a sigh, maybe -4. So imagine having to overcome -8. So you can easily see how exhaustion develops very, very quickly. And they just can't keep up, and the hyperdynamic inflation gets worse. They have to overcome it. And this can get as high as 10 or 12. So look at what they're having to overcome with every breath just to move air. And this is why they go into respiratory failure, because what happens is they only generate -6 now, or -4, because they're exhausted. Then they're not moving air. CO2 accumulates, they go into respiratory failure. And these are the people that die because they get hypercapnic, and then they get hypoxic, and then they go on to die. And again, 10% mortality. So pretty high. So with non-invasive ventilation, what you do then is say, okay, let me put +8 up there. Let me put some pressure in that airway. Not only does it do one thing, because remember, the lung doesn't look like that. If I have +8 here and it's sitting over this airway as an alveoli, because remember, lungs are like brake, a group of brakes. That 8, if this is 4, it's going to compress that airway. But if I match this, I will splint open these airways. And more importantly, what happens to move air, all I need is greater than -1, really greater than 0, minus on the minus side, right? So this is why the next thing you do, you try these medical therapies, they're looking exhaust and fail, non-invasive ventilation, next best step. Again, you're buying time for the magnesium to work, for the steroids to work, but this is why it works so well if you can get a kid to relax to it. The problem is you put a mask on them and they're short of breath. That's like you walking up 10 flights of stairs and someone, right? It's just very uncomfortable. It's very important that your respiratory therapists do it correctly. And sometimes you got to coax them into doing it correctly, because the knee jerk is, let's put it on, strap them on, and walk away. I'll adjust the machine. What they have to do, and this has been shown in several studies, is to hold it on the child, and the child starts to take it off. Give them a second, put it back on. What happens is, if you keep doing that repetitively, they start seeing every time that mask is on, actually feel better, actually breathe better. And then after 5 minutes, and it's only 5 minutes, they don't have to stand there for an hour. 5 minutes of that, I'm sorry, no, it was 10 minutes of that, they had improved their success rate by almost 80%. Just hand holding it for a minute. And then, once they get on it, okay, I want to strap it on now, and they feel better. So it takes that respiratory therapist, they just can't strap it on and walk away. And if they do, bring them back. Say, let's try this again. Because what they'll do is say, oh, it's failed, let's intubate them. Invasive ventilation is not the friend of an asthmatic. It's one of the worst things you can do to an asthmatic. And the reason is because you're putting positive airway pressure into a hyperdynamic lung anyway. And if you don't do it correctly, or you do it too much, then you cause barotrauma. What's going to kill an asthmatic quicker than pneumothorax? Not much. They will die on you very, very quickly. But if you do an expiratory hold, you put them on the ventilator and do an expiratory hold, you can actually measure what that Autopeep is, what that alveoli peep is. And then you set your peep to that. And that does the same thing as that non-invasive ventilation. It just makes it so they have no real airway gradient. You keep their peak pressures less than 35. You put them on a respiratory rate not determined by their PCO2, by their expiratory time. Because if I give them, if they take a breath, and you can see it, if this is baseline, and you give them a breath with a ventilator, and it takes them forever to exhale, and this could be 8 seconds, could be 10 seconds. If that's 10 seconds, the greatest rate I can give them is 6. Because if I give them a breath here, what happens to that dynamic inflation? It gets worse. I make their Autopeep worse. So what happens is the next breath, they do this, then I give them a breath, and they keep doing that. And you make the Autopeep even worse and worse and worse. So the goal is determined by your expiratory time. And the goal is not to make a normal VBG or an ABG. The goal is to make it acceptable. What can I live with? And sometimes you have to live with a CO2 of 90 in a kid, and just live with it. And of course, treat hypoxemia, which is usually not that difficult in an asthmatic. Well, what if we do something like this? And I'll give you a case report. This is a 13-year-old, came into the emergency room in extreme respiratory distress, was obviously over that curve, intubated, ventilated with 2 milliliters per kilo, and that had a peak pressure greater than 50. Took this person 15 seconds to exhale. So if you looked at it on the monitor, it took them 15 seconds before their airways were completely. So what's the fastest rate we could give them? It's 4. If we gave them 4 more than, or anything more than that, we would be harming them. PCO2 was 188. Not real acceptable. NPH 6.8. Only a kid would tolerate that, right? Adults should be doing CPR. Here's another, is 10-year-old with asthma, wheezing, received beta-adrenergic inhaler therapy, improved. Again, African-American male, gave beta-adrenergic therapy, improved a little bit, but also got some steroids. Mom was sent home and said, give some more treatments, came back, actually in severe respiratory distress 30 minutes later. And look at the CO2. They left with a CO2 high. He was just tired, so he looked better. If you really look at it, it was just missed because he wasn't wheezing. Well, he wasn't wheezing because he wasn't moving enough air to wheeze. So anyway, he was immediately intubated. And if you look, his CO2 was over 100. We put on Avcor, which I'll show you a picture of, and we were able to drop it immediately and almost turn off the machine. And what is Avcor? It's arterial venous CO2 removal. So what we do basically is you have an asthmatic, we put in an arterial and a venous line, and we hook them up to this little device, which is actually just a hollow fiber, low resistance oxygenator, and we run oxygen through it, and that oxygen pulls off the CO2. Because CO2 has a volatility of about 40 times that of oxygen. So it readily wants to get out of the system. And so you're just allowing it away. So what it does is this will remove almost total CO2, and you can virtually turn off the ventilator. We basically just put them on CPAP. So that's CPAP, because remember, you don't need breaths to oxygenate. Oxygenation is a passive movement. You only need breaths to remove CO2. So if you dilate the alveolus and just make it open so that the capillary has surface area, you will oxygenate. You do not need a breath. And we've proven this because when we tested this, actually in adults, we put in the arterial venous line and actually put them on CPAP and paralyzed them for an hour. And with 0 breaths, and their PCO2 would be 40, their PO2 would be 200 something. So anyway, it's a neat device. We have it here. We have kits. We can get it bedside. We can have it on in 15 minutes. Again, I'm not sure what that picture is. but here it is again, and this is a kid just 6 months ago that came in, severe asthma, same thing. PCO2 was I think 160. Could not ventilate. His expiratory time was about 12 seconds. He actually ended up dying of cerebral edema because he was actually coded at home without mom telling anyone. He had actually got return of spontaneous circulation pretty much on his own. But African American male. What was his primary treatment? Albuterol inhaler. So again, probably one of those polymorphisms. So it has implications, this polymorphisms, not only for the ICU, but also for clinic, because we really have to understand that we have a high density of that in this population. And then we can always go on full bore ECMO if we need to. And we've had to do that with smaller babies because we can do it to about, I think we've done to, our youngest AVCOR is 4, but it was a big 4. So usually about 6 and above. Below that, we usually go with ECMO. We're actually testing a machine now that's pretty small that does low flow CO2 removal with a venous cannula that's not much bigger than a dialysis cannula. And we're going to be looking at that in the next 6 months or so. And that would be great for asthmatics because you could virtually turn the ventilator off and just put them on a little bit of CPAP or non-invasive, not even have to intubate them, and just for oxygenation. That makes sense? Any questions on asthma? Pretty easy stuff, right? But just, like I said, beware of that exhaustion. And don't confuse exhaustion. Oh, he's better, he went to sleep. You know, it may fool you. And asthma is one of the scariest diseases I think we treat because there's so many presentations and they do it, they're sneaky and they're out to hurt you, trip you up, I think. All right, well, let's go on to the other thing that we see quite a bit is intracranial hypertension. Y'all remember this from med school. ICP minus the mean arterial pressure is the cerebral perfusion pressure. Cerebral perfusion pressure is really what determines the brain. And the Monroe-Kelly hypothesis. Y'all remember that from med school? Monroe-Kelly says there's 3 things in the brain. There's fluid, brain, and blood. And if you increase any of those, you have to decrease one of the others, or you will get intracranial hypertension. That's basically what it says. It's actually a hypothesis. It's not been proven, but it seems to make sense. And at least it gives you a visual that one of those things have to be done. So the first thing that you'll see, you get a kid comes in, his ATV, hits his head, the CT shows some brain edema. One of the first things neurosurgeons will usually do is put in here a bolt, but it shouldn't always. But a drain, I'll put in a interventricular drain, and it's really to reduce the CSF. Again, fluid, which is CSF, brain and blood. I can't stop blood and brain, but I can reduce that fluid and try to reduce pressure. So that's the first thing you do. And the second thing you do is improve venous drainage, try to get the blood out of the brain as quick as you can. So you put in that, you sit them up quickly, and then hopefully that'll decrease the brain edema, or you can do it actively. The way that we decrease brain edema is you'll see mannitol is one of the first. The reason why we use it first is one, it's readily available. You don't have to, you can keep it in the dye bulb. Nurses can get to it quickly. It also has some free radical scavenging effects and some probably some other effects with sulfites that seem to reduce some of the edema. However, the problem is mannitol is a diuretic, and that can be good or bad. If it's a diuretic, yes, it pulls fluid out of the brain, puts it in the vascular space, but then it goes to the kidneys and you pee more. If that drops your mean arterial pressure, what does that do to your CPP? It drops it. So what we do here is, although I'll usually give this in the emergency room, or if it's severe and I can't wait for pharmacy to come up, go ahead and give the mannitol. But then what we do is give hypotonic saline. And that's 7.5, 14, or 23%. And that's usually the discretion of the attending. Actually, pharmacy hates when we do this. They actually, most of the time won't give it, so we get 14%. Just double the volume, but you get mostly the same effect. And what it does, it produces a hypertonicity. And remember, the brain and the meninges works very, very hard to keep sodium regulated. So it will pump out and keep that sodium level pretty constant in the brain. But if you make it in the vascular space, a sodium of 155, and your brain sodium is 140, where's the fluid going to go? Right? But it's going to go out. And that's what you do is you maintain a specific sodium gradient. So we will target sodiums of 150 to 160. And that's perfectly normal. And that's what you want. And we'll do that. We can't do it continuously. We can do it with bolus. Usually just doing boluses regularly will maintain that type of sodium. Then the next thing we do is sedate them because you don't want them active, because you don't want them to raise their intracranial pressure. So we sedate them pretty heavily, sometimes paralysis, seizure prophylaxis, and repetitive CAT scans. They'll usually do CAT scans at least 6 hours after a presentation of the first one, sometimes more often. And then one of the other things we're looking at is oxygen utilization, but I'm not going to go into that. And that's really it for intracranial hypertension. And really, one of the things that we have here is the neurosurgeons are busy. They may be in the operating room, and you call them, we'll send someone, you can't wait. So get your attending involved very, very early and say, look, this ICP is 22, it's steady, it's been that way for 15 minutes. Call neurosurgery, they want another CAT scan. Well, radiation does not cure brain edema. We've proven that over and over and over again when they have 75 CAT scans. Go ahead and call Kelsey and say, I need 14.5% saline, get it up. And it's for 7.5% saline, it's 2 cc's per kilo. So it's a very simple formula, it's easy to remember. If you get a 23%, it's really about 0.75 cc's per kilo. But you give that and then get your sodium, and you have to have a monitor of the ICP. And if it doesn't fall, then you keep calling neurosurgery, and because the ultimate way to treat it is take the skull off and do a craniectomy. And we force them a lot of times to do that, particularly in refractory CSF. So start it, recognize it, but get your attending involved soon, and that'll save you a lot of heartache. And again, the nurses will really, really save you almost all the time. So tap into their knowledge. Like I said, it may be your first ICP catastrophe, but it's their 50th. And they pretty much know how to do it. So any questions on those? I told you it's pretty short, pretty easy. Any other PICU dilemmas?
What is your drug of choice for sedation for brain injury patients?
I like propofol. It's a double-edged sword because it can lower your blood pressure. So if they're tanked real well and they have an adequate blood pressure, I like it because I can stop it quick and do a neuro exam within 15 minutes. That's my absolute favorite. Dexmedetomidine also. So I use a combination. Put them on pretty high dex. The problem with dex is it's usually started way too low. And so I rapidly go up, start at 0.5 or 0.7, and then go up, get to 2 pretty quick, and then add propofol along the way. If they really have high ICPs, paralyze them.
Yeah, there was some studies that were put out about different sedatory medications and their negative effects on brain injury. And so I was talking to neurosurgery about it. They didn't seem that, but Conrad and I were talking about it.
Yeah.
And that's where it came up about the use of what's the best sedative. And of course, neurosurgery was like, we don't care. There's no evidence supporting it.
Because they don't read literature.
Well,
They don't read their own literature.
Oh,
So.
I totally agree with that. But yeah, because I knew there was a bunch of those studies that had come out. Granted, they're all mostly in adult patients and not peds patients, but.
Well, the mitochondria of the brain doesn't care if you're 2 years old or 22 years old.
Yeah.
So, there's a lot of art to ICP management, but the people that do it the worst are the people that should do it the best.
Yeah, of course.
I'll leave it at that. How's that sound?
That's perfect.
Wasn't that PC of me? Thank y'all.